And one of the things that I want to start by reminding you is that although we think of pregnancy as a normal event for most women, there are potential health problems in any woman who is pregnant. And we mustn't assume that everything that happens to a woman with lupus during pregnancy is happening just because of her disease or just because of her drugs, and that they must be responsible. All women during pregnancy have an increased risk of infection. The immune system, which is there to fight infection, is damped down deliberately during pregnancy to reduce the risk of the mother attacking the baby because it has components that came from the father. There are hormonal changes in pregnancy that are much, much greater than the hormonal changes of taking a contraceptive pill or hormone replacement therapy. And the natural hormones can increase the risk of blood clots during pregnancy and after pregnancy. The hormone changes can also increase the risk of diabetes, particularly in people who are prone to it. Some people have a family history of diabetes or come from a racial or ethnic background that's more prone to diabetes than others. And the rate of diabetes in pregnancy in some studies, even in healthy women, is up to 18%. So it's not just due to steroids in pregnancy, although we will touch on that later. Similarly, high blood pressure can occur in any woman during pregnancy. 3 to 5% of healthy women can have a high blood pressure condition called preeclampsia. So again, it might have happened anyway, even if it happens during pregnancy due to lupus. And the same applies to miscarriage and stillbirth. Unfortunately, women with lupus, and we'll talk a little bit about which ones, may have a higher risk if they've got lupus than the normal population. But it actually can happen, unfortunately, to any woman. So it isn't always the disease and it isn't always the drugs. And the same with the outcome of babies. There's a risk of 3% developing some sort of abnormality due usually to genetic factors that would have happened anyway. It's not necessarily, as I say, the disease or the drugs. So just keep all that in mind as we talk through some of the issues that have been reported in women with lupus, which may occur slightly more frequently and are a reason why we need to have women on drugs to prevent them from having a worse outcome than they would have had otherwise, and actually to try and restore their disordered immune system, which is what we all know is why people get lupus in the first place, more to a normal state so that their risks are no greater than the risks of other women during pregnancy. Certainly having lupus disease has been known to increase the risk of complications in pregnancy, and one of the most important complications is a flare of the lupus disease. It's also possible to have a higher risk of high blood pressure, particularly if there's a history of having kidney disease in the past. And patients on steroids will fall into the category of those that are slightly more at risk of diabetes than other people. And drugs used to control lupus may increase the risk of infection, but there isn't a lot of evidence that it's a lot greater than it would have been otherwise. The ones with antiphospholipid antibodies, which are antibodies that make the blood sticky and can occur in lupus, although this can occur as an independent syndrome called antiphospholipid syndrome or Hughes syndrome or just sticky blood syndrome, is obviously associated with an increased risk of blood clots out of pregnancy, and that risk of blood clots is greater in pregnancy. So women with that condition will definitely need drugs to prevent blood clots during pregnancy. And the phenomenon of these antibodies and the way they work on the body can increase the risk of this condition, preeclampsia, a condition of high blood pressure with protein in the urine and swollen ankles during pregnancy. And some of the women with antiphospholipid syndrome, whether it's on its own or with lupus, have a higher risk of severe preeclampsia and of getting it earlier in pregnancy. And we try and avoid that with treatment these days. And all our aims are to try and reduce the risk of miscarriage and stillbirth, which we found in the past was increased in patients with lupus in Birmingham. One of the first surveys I did of lupus in Birmingham when I came back in 1992 was to find that the risk of stillbirth in women with lupus was 3%, 10 times higher than the normal population. And that was one of the things that set up my interest in developing a clinic for women with lupus at Birmingham Women's Hospital. We now see patients with many different rheumatic diseases, not just lupus, and antiphospholipid syndrome. And it was to look at the outcome of the children born to mothers with lupus, as I mentioned earlier, that I got a grant to study this further, and we'll come back to that later. So how does the lupus present with flares? All sorts of different things. The skin rashes, like outside of pregnancy. The doctors do have to distinguish some rashes that can occur in normal people during pregnancy So everything that happens in pregnancy isn't always the disease, and you do need people who are experienced at managing lupus and pregnancy, which is why many women do come to a combined clinic that I do at Birmingham Women's Hospital. And we do provide advice to other units if they need it for women who can't attend our hospital. The risk of flare varies depending on the studies done, where they were done, what type of patients. The racial background has an effect, as it does outside of pregnancy. People from an Afro-Caribbean background in the UK or African-American in the US are more at risk of flare at all time, and people who've had a history of kidney disease are more at risk of flare, and are all the more likely to need to stay on drugs during pregnancy to prevent them getting a deterioration in their disease which would compromise the development of the baby inside the mother. The outcome for the baby is best if the mother's disease is not active when they become pregnant, and if she's already on appropriate drugs to keep the disease suppressed. So why do we need to keep the disease suppressed? Studies, particularly from America, where there's a great trend to actually stop all the drugs and leave the woman without any treatment, has shown that women have a higher risk of miscarriage and stillbirth if they are not on treatment and if their disease flares. It may not be a huge risk, but it's a significant risk. So patients with low disease activity from lupus had a risk of losing babies of 23%, which meant that 77% survived, compared to those with very low, sorry, that was with high disease activity, whereas those with very low disease activity, only 12% lost their baby for a variety of reasons. And you have to bear in mind 10% might have gone not survived anyway, so it's only very slightly higher than background rate. But that's an 11% difference because of the disease activity. And the risk has been estimated in some studies to be 3 times higher if you have high disease activity than low disease activity, whether that occurs at the time of the pregnancy start or develops during pregnancy. So you really don't want active disease because it risks compromising the blood flow in the placenta, which feeds the baby and leads to poor growth, and ultimately, if the baby cannot be delivered in time and with severe growth deficiency is marked, then they can end up dying, unfortunately, at various stages of pregnancy. What we do now in practice is try and deliver them before the baby's health is compromised severely. Obviously, it depends on what stage in the pregnancy growth slows down. And we have found that patients who have very high disease activity are all the more likely to need an early delivery before 37 weeks. So in one study, it was 74% of those with high disease activity needed an early delivery, whereas those with low disease activity, only 39% needed delivery. They didn't in this study have many patients with no disease activity at all, so there's no data for that. And when they are born, if they have had a deficient placenta, which feeds the baby, and it's not been working properly, then the babies may be small for the expected size at the age at which they're born, or the duration of pregnancy at which they're born. So we know that the risk of having a baby that doesn't survive is increased by having a history of previous miscarriage or stillbirth, having very active disease, particularly at the time that the baby is conceived and during the pregnancy, having the presence of these antiphospholipid antibodies or low platelets, which are often due to antiphospholipid antibodies that make the blood sticky and make the placenta not work properly. And if high blood pressure develops during pregnancy or high blood pressure in the lung circulation, those can all increase the risk of the baby not growing normally and having a higher risk of miscarriage, stillbirth, or the need for premature delivery. These other conditions are less common but can be causes of the baby not doing so well. Preeclampsia, the high blood pressure condition, diabetes, particularly if it's uncontrolled, but usually it can be managed actively by diet and, if necessary, insulin, and premature rupture of membranes, which can bring on the delivery early. So babies do sometimes need delivery early because of poor growth or the preeclampsia, or because they're distressed. These other causes are less common. And if a baby is born before 38 weeks, whatever the underlying cause, it is at increased risk of breathing problems, which we can try and avoid by giving injections to improve the maturation of the lungs so that they do work better when the baby is born. The baby may have feeding difficulties, it may not be able to suck and swallow properly, and there is a higher rate of infection which increases for every week earlier before week 38 that a baby is born. Some babies' livers don't work very well either if they're born early, and they can be jaundiced and need to have UV light exposure, which sometimes brings out a rash in the baby. And some babies, unfortunately, will die as a consequence of one or more of those things or other things that are less common and aren't listed on this slide. And unfortunately, a few will go on to develop developmental abnormalities, particularly of the nervous system, if they were born early and there have been problems with their growth before they were born. So the aim of treatment is very much to prevent all these complications. All of these things can happen in people who are perfectly healthy, but there is a slightly higher risk in lupus, and the risk is highest in those with active disease, flares of lupus, all the clinical manifestations you're aware of, particularly the objective ones. We find it hard to interpret fatigue in pregnancy because it's, many women may be fatigued, but the more objective signs and symptoms of lupus can be worrying, and we need to prevent them both before the woman becomes pregnant and all through the pregnancy by using appropriate drugs. So what are the appropriate drugs to prevent these complications? We can use simple things like paracetamol for pain relief, but that isn't going to make a difference to the disease process. The drugs that have been shown in the past, and I'll give you a bit more information about them in a moment, are prednisolone, hydroxychloroquine. Hydroxychloroquine is also known as Preeclampsia, and occasionally there's a version called Quinoric that the chemist might give you, and then there's azathioprine. We do occasionally use cyclosporine or tacrolimus, but I'm not going to talk about those today because they're very rare and there's very little data about their use. And I'm not going to talk much about the use of aspirin or subcutaneous heparin to thin the blood. We use aspirin in all our lupus patients in Birmingham to prevent preeclampsia. And it's been shown in big studies of healthy women, big studies of women with risks of preeclampsia for many different reasons, that aspirin can reduce the risk of complications from preeclampsia. So it's standard in our group to give that to all women with lupus in pregnancy unless they can't take it. And people who have blood clots in the past, particularly those with antiphospholipid syndrome, we give subcutaneous heparin instead of warfarin during pregnancy, usually with aspirin, because warfarin can cause congenital abnormalities, so you have to avoid that. And I'm not going to say any more about aspirin or subcutaneous heparin because the indications for using that to thin the blood are very clear, and there's nothing very new about that. But the area that has caused more perhaps concern for some people is what the evidence is for these three drugs, prednisolone, hydroxychloroquine and azathioprine, to be used in pregnancy. And we do get messages that patients are often given conflicting advice. In fact, I did a survey with Lupus Europe, and we found evidence of a lot of conflicting information about patients getting advice on pregnancy and what drugs to use and when to become pregnant. And I find it even in our own hospitals. Sometimes the pharmacists give completely different advice to the doctors, and sometimes even the midwives on the wards will give different advice. And we're trying to standardise that. And I've been doing a lot of work with the British Society of Rheumatology and with Ian Giles from University College Hospital, London, to develop new guidelines for drug use in pregnancy for all women and to provide the evidence that's robust and up to the standards of NICE, the National Institute for Clinical Excellence, so that there will be less doubt about who should be using which drugs in which situation. And the work that we've done for that, those guidelines which were presented last week at the British Society of Rheumatology, form the basis of some of what I'm going to discuss with you and show you today. So one of the things that some people take for pain is ibuprofen or Nurofen. You can buy it over the counter. We tend not to recommend it much in lupus, certainly not in people with kidney disease, but it's not a drug we recommend in the first 3 months of pregnancy. It can interfere with fertility occasionally. It doesn't usually do so, so only if women are having trouble conceiving would we recommend stopping it before pregnancy if they need it, but we tend to recommend intermittent use anyway rather than regular use. There is some evidence that it has a small risk of miscarriage and therefore should be avoided in women who already have miscarriage or have other reasons for miscarriage like antiphospholipid syndrome. And there has been studies suggesting there is a small risk of congenital abnormalities, which is not widely recognised, but I think is sufficient to avoid using this drug in the first 12 weeks of pregnancy, particularly in women with lupus, where there may be other risks from this to do with their kidney function and blood pressure. There's also some evidence if people do stay on this type of drug later in pregnancy, it may delay delivery, but more seriously, it can actually cause heart problems, a particular structural problem in the heart if it's continued after 32 weeks. So if it is given at all in pregnancy, it must be stopped before 32 weeks or at 32 weeks, which is before most women will deliver. If there's any reason to believe they might deliver earlier, then we don't recommend taking it at all. And I think it's important people are aware of this just because this is a drug available over the counter. Paracetamol is much safer, and if it isn't sufficient, we recommend adding codeine. Codeine can have some risks, but most of them are treatable or reversible, even if the drug is used in fairly high dose. So it's not an ideal drug because it's quite a strong painkiller, but it's safer than ibuprofen. It doesn't cause congenital abnormalities. Steroids have been used for many years for many diseases in pregnancy. They are safe in women who are trying to become pregnant, they're safe in pregnancy, and they are safe in breastfeeding. The prednisolone, which we use most often in this country, and many of you may have been given this, is actually inactivated by an enzyme in the placenta, so it actually doesn't get into the baby's circulation. Less than 10% will ever cross the placenta, and less than 10% gets into breast milk. And even the American Academy of Pediatrics, who are very conservative about what drugs they will approve, have approved this drug for many years. Dexamethasone and betamethasone are different types of steroid, which we deliberately use in some women in pregnancy to mature the lungs, but they have to be used with caution because they do cross into the baby and you don't want to give too much of them. But those are things that you would not be likely to come across unless you had some complication in pregnancy anyway. If you have very high doses of steroids, more than 15 milligrams a day for many weeks in pregnancy, there is some data showing an increased risk of premature rupture of membranes, which can bring on delivery. There's certainly evidence of it increasing the risk of diabetes, high blood pressure and preeclampsia, and it may thin the bones, give you osteoporosis. All women in pregnancy get some degree of osteoporosis, and anyone on heparin will be at increased risk of osteoporosis, and steroids can make that worse. But it's rare to get fractures from steroid use in pregnancy. Most women don't get fractures from steroids till after the menopause, unless they have heparin as well. There are exceptions, but certainly for the average woman on lower doses of steroids, this isn't a serious risk, although it's one that we try and avoid by giving calcium and vitamin D3. And steroids can increase the risk of infection, and high doses are certainly more of a risk factor for that. And sometimes we have to use antibiotics around the time of delivery if women are on very high doses of steroids to prevent complications from infection at the time of delivery. But this is a very useful drug. It's been shown to be very safe for a long time, and it is appropriate to use it. But as with most things, and particularly in pregnancy, we try and keep the doses as low as possible. Hydroxychloroquine is another drug which has been around for a long time, and people are aware that it's safe in pregnancy and breastfeeding, but there are a number of people who don't seem to have seen the literature. There's no evidence of it causing congenital malformations. There was some evidence of another drug called chloroquine causing problems with the eye and the ear, but this has never been observed with hydroxychloroquine. And it seems to be very safe in pregnancy, and there have been some studies in America suggesting it may even prevent a complication of pregnancy in some lupus women who have antibodies called anti-Ro or anti-Love, whereby their baby has a 1% risk of congenital heart block. And it looks like it can reduce that risk by about half, although we've not demonstrated that in our study, but we didn't have such high-risk patients as they had in America. The hydroxychloroquine can reduce disease activity, and in trials where they took half the women off the hydroxychloroquine and left half of them on it, they found those who stayed on it had lower disease activity, less steroids, their deliveries were more likely to be at the normal time, and the scores on the baby when they were born according to standard criteria were better. And there was another study later on a bigger number of women confirming lower disease activity, lower doses of steroids in the women who had hydroxychloroquine, so higher disease activity and higher doses of steroids in the people who stopped it, better disease activity and less steroids in the women who stayed on it. And again, the American Academy of Pediatrics approves of hydroxychloroquine for pregnancy and breastfeeding. So there shouldn't be as much doubt about its use as there seems to be in the UK among the pharmacists in particular. Azathioprine is a drug that there's been more concern about, but it has been used in a variety of different diseases for a long time. Over 30 years in Birmingham, we've used it in lupus, vasculitis, kidney disease, particularly the transplant patients, and in rheumatoid. It's also been widely used by gastroenterologists for inflammatory bowel disease and by haematologists for people who've had certain malignancies and been pregnant and needed treatment. There was concern that it might theoretically cause congenital abnormalities, but no reports of any particular abnormalities have ever been found. No increased risk of miscarriages or stillbirths, no effect on fertility. It seems to be safe at the time of conception and during pregnancy. And one of the reasons that it probably is safe for the baby is that the baby's liver can't activate the drug to the active form. So it's not actually exposed to the drug in any serious, meaningful amounts. There are very low amounts of it in breast milk and very little evidence of harm to the baby from it. And the liver dysfunction, which you test for in mothers, it doesn't get found in the babies either. Very low risk of infection and no evidence that it stops babies responding to vaccines. And there's so far no evidence of ever causing cancer in the children. And it does seem to be safe in the doses that most women have received, which is normal practice. So that's where we are with what's been the published literature. Our own work on hydroxychloroquine and azathioprine is what I'm going to touch on here. Now, I've got very confused about what time I started and what time I'm meant to finish. So I don't know quite how much detail to give you. Can someone tell me how much more time I should talk for? About 5 minutes? Okay. So what we set out to do was look at whether these two drugs, hydroxychloroquine or azathioprine, have an impact on preeclampsia, congenital anomalies, that's including heart block, because there was this evidence that hydroxychloroquine might reduce it, and the long-term outcomes of children in terms of developmental problems, visits to hospital, and hospital admissions for infections. We've done the study in 8 centres in the UK, and we included women with lupus by standard criteria and excluded those who had children born before the mother had a diagnosis of lupus by standard criteria. Women were assessed once. Some of you in the room may have contributed to this study. We started it well over 5 years ago, but it's taken a while to complete the analysis on the data from all the centres. The centres started at different times. At the end of the day, we had 287 children born to 200 women, because some women have more than one child. We had a few sets of twins, most of them were women with 2 children and occasionally 3. In terms of the numbers getting the drugs, if we just look up here at the top side, we had 149 children exposed to hydroxychloroquine and 89 exposed to azathioprine. And in terms of the antibodies that the mother had that might put them at risk of various complications from their lupus disease, including antiphospholipid syndrome, there was no difference. In terms of kidney disease, those on hydroxychloroquine or not on hydroxychloroquine was not different. There was no difference in previous high blood pressure, and there was no difference in preeclampsia. In terms of the drug exposures, in addition to hydroxychloroquine, the women who had hydroxychloroquine, 66% of them were on steroids compared to 51% on steroids without hydroxychloroquine. 30% were on heparin with hydroxychloroquine, and 18% were on heparin without hydroxychloroquine. Those were the only ones that were slightly different in terms of other drug exposures. But in general, they were very similar types of patient, both on hydroxychloroquine and not on hydroxychloroquine. When we looked at azathioprine, the background information about the women on it was that there was substantially more with kidney disease. 57% had kidney disease in those on azathioprine, the children exposed to azathioprine. The mothers were on it, but the children were exposed in pregnancy. And not on azathioprine, only 16%. So kidney disease suggested a more severe group of patients were being exposed to azathioprine in pregnancy, which is what you'd expect, because you wouldn't use it for milder disease. And in terms of those on azathioprine, they had a higher use of aspirin. 83% of those exposed to azathioprine were also exposed to aspirin in the mother, compared with 66% not. So this also went with more kidney disease and more expected risk of preeclampsia, hence use of aspirin in those women. So that's the sort of background information about them. What about the outcome of the children? So as I said, in total, there were 287 children born to 200 women, and 149 were on hydroxychloroquine, 138 not on. The mean weight of all the babies was about 2.8 kilograms, and the duration of pregnancy was 38 weeks, with a range that started at 25, which is when they're just viable, up to 42, which is the maximum we let women go to, and we usually do deliver spontaneously or risk dying if they stay in utero too long. The mean duration of pregnancy, or the average duration of pregnancy in healthy women, is 40 weeks. When we looked at azathioprine, however, they were born a little bit earlier. The median time of birth was 36 weeks. Whereas those not on azathioprine, it was 38 weeks. So remember, they were the ones who had a history of kidney disease, and they are known to have a higher risk of problems in pregnancy, and particularly of placental dysfunction. And sure enough, the babies were slightly lighter. They were 2.8 kilograms on average, and for reasons that's similar to the ones on or off hydroxychloroquine. But the ones not on azathioprine seem to be a little bit bigger. May possibly be due to steroids, but we can't really assess that. Because the vast majority of women on azathioprine are also on steroids, which I think I forgot to tell you. So we then looked at congenital anomalies, or any physical abnormality in the baby when it was born, and there were only 6 in total, and there was absolutely no difference in those on or off hydroxychloroquine, and the data for azathioprine was almost identical. There was a slight difference in neonatal lupus syndrome, and we had expected to have less skin rash in those on hydroxychloroquine, and we found that, and we had slightly less heart block, but you couldn't say that 3 versus 4 was significant. So we had to say that in terms of these abnormalities, there was no difference between those on hydroxychloroquine and those not on hydroxychloroquine, and it was very similar but slightly different data if we divided them based on azathioprine. But certainly no evidence of congenital abnormalities, no physical abnormality that could be attributable to the azathioprine group exposure. When we looked at hydroxychloroquine treatment in terms of visits to hospital, which is in this column, we found that less patients needed outpatients if they were on hydroxychloroquine, less children needed outpatient visits during childhood if they had been exposed to hydroxychloroquine in pregnancy, 12% compared to 22% not exposed to hydroxychloroquine. And for infection requiring hospital admission, it was also reduced, 13% compared to 24%. So it looked, if anything, as if hydroxychloroquine might have done them some good at protecting them against something that the others had a problem with, but we can't identify what that was. When we looked at the same issues in those either on azathioprine in this column or not on azathioprine in this column, the thing that stood out was actually the other way around. Azathioprine was associated with a higher risk of going to hospital with an infection during childhood at 28%, whereas those not on azathioprine, it was 14%, and the average was 18% for all of them. I thought 18% was quite high, but I've asked around a few people and I've tried to find data for the normal population to see if lupus itself is increasing the risk of infection in children. But it's very hard to establish the data, and all of this data is very influenced by the age of birth. And it is extremely clear that the difference between an average birth at 36 weeks compared to 38 weeks is enough to explain that increased risk of infection in the children, because for every week you're born earlier than 38 weeks, there is an increased risk of infection. And we had some very small children, both low birth weight and short duration of pregnancy in the azathioprine group, which meant that they were going to be more at risk of infection irrespective of the drug. And we did various statistical analysis, particularly looking at the risk associated with the renal disease itself, and it certainly showed up that the risk of infection seemed to be more related to renal disease than anything else, just to cut a long story short. So azathioprine didn't appear to increase any complications as long as you controlled for the type of disease the women had. And hydroxychloroquine probably was given to slightly milder women. It's not entirely clear that it was actually beneficial to the children, but it certainly didn't do any harm. And developmental problems were rare. This shows developmental delay, special needs, attention deficit disorder and special schooling. Blue is the total number, and this is the data for azathioprine and hydroxychloroquine was similar, and the numbers are all terribly small, but there's certainly no trend or significant difference. But there was a group in America who thought that azathioprine might increase the risk of developmental problems. But I have a feeling that it's again linked to the fact that it tends to be the more severe patients who have it, because there's now evidence that antibodies can cross the placenta and affect development of the babies anyway, and therefore women who have more antibodies and are sicker are more likely to have children with these abnormalities. But the absolute risk is incredibly low, so don't go away and think this is going to be very high. These are small numbers overall, and there's a lot of variation in the normal population, and again, the time at which the baby is born, and some of our babies were born as low as 25 weeks, as short as 25 weeks of pregnancy. That's more than enough to explain why some of them ran into problems. So the conclusion of our research was that we didn't find any significant differences between those exposed to hydroxychloroquine or azathioprine and those not, in terms of preeclampsia, congenital abnormalities, congenital heart block, admissions to hospital for infection, other inpatient or outpatient admissions, and no significant difference in developmental delays, which was very reassuring. So what was that conclusion? With planned pregnancies, careful monitoring, coordinated management, and appropriate drugs, most mothers do have successful pregnancies. That's what I'd like you to take away as a message. And there's thanks to the people who've worked with me over the years on the clinic and this issue. I have to say, Bernard Rhodes' name hasn't quite joined this list, I realise, today with him in the audience, because he only joined our clinic in the last year. And most of what I've presented has been done over the last 7 or 8 years. Thank you very much.